Wonderful. So I'd like to invite all four speakers to come up to the front. If you have questions, please write them down on the card and send them to the end of the row, and I'll collate them and ask them. And I'm going to start with the first one. I think I warned Jeanette that I may ask this. I hope I did. So in the clinic, I'm often asked about marijuana, CBD, cannabis, things like that in terms of cancer prevention or treatment or side effects and things. So, Jeanette, have you thought about that? And is there any evidence, data for the role of cannabis in prostate cancer? Oh, sorry. No, I need the microphone.
Hello. Okay. Oh gosh. Sorry. So I am by no means an expert in that arena, and I feel like there are people way better qualified to answer those types of questions. And I feel like it is a hot topic, and I feel that's something that we should be thinking about. Research funding is just not really there because it's research dollars are just not there to conduct really good clinical trials or well-designed trials in that area because of the nature of the substance. But I do believe that there's some people at the University of Washington who might be investigating that in some arena.
Yeah, I would agree. It's a very understudied area, not a lot of hard data
Right.
where we can make evidence-based decisions. It is an open clinical question. As you know, it is legal in the state of Washington. So my counseling generally is let your physician know and discuss it with them. I think there is active research going, not a lot, again, of hard recommendations. So I'm going to stay with you, Jeanette. Are there any branded supplements that you would recommend for a man with prostate cancer in this case?
I don't tend to recommend any specific brand. I feel like as a researcher, that's kind of a conflict of interest for me. So it's really your comfortability in discussing it with your physician. Again, I think there's things you can do to ensure the quality of what you're taking, making sure that it's been tested and it has one of those seals that says that what's in it is actually what's on the label and there's no contaminants. So that's a good place to start.
Okay. Marion, is turmeric beneficial? Or turmeric?
Yeah, turmeric is a spice, and it's most commonly known in Indian cuisine. There's a lot of really interesting research using turmeric on either cells or in animal models of cancer that seems very promising, that it may reduce inflammation, may reduce the size of tumors. There isn't yet any good data from humans, but it does appear to have some interesting biological properties.
Can I add to that?
Sure, you bet.
I will say that the one thing about turmeric is it's not really well absorbed by the body, so something to keep in mind if it's something you're interested in taking.
So for both Jeanette and Marion, how about fish oil and statins? We got 100 questions here, so you got to...
So there have been some studies looking at blood markers of omega-3 fatty acids that have been largely inconclusive. Some have increased risk, some have decreased risk. There was actually just a study published, the VITAL study, which is the first study I've seen looking at prostate cancer for a large randomized controlled trial of omega-3 supplements, and it found no effect for prostate cancer risk. Or heart disease, yeah.
And John said, and heart disease, and that's correct. And I'll just add to that, the ingredient that is the important one in the fish oil is the long-chain fatty acids, sometimes called N3 or omega-3s, as Jeanette said. And this is one of those nutrients that, again, falls in the sweet spot. We can actually make omega-3s from some precursor fatty acids called linolenic or alpha-linolenic. But those enzymes work very slowly, so the best way to get it is from preformed long-chain omega-3s that we primarily get from fish. But again, it's one of those things where if you get too much, then it will likely increase your risk. So again, it's this sweet spot where we can try to determine the optimal amount for health based on the type of nutrition research that we do.
So I'm going to stick with both of you again. How about melatonin and resveratrol?
Well, I'll take a shot at melatonin, and then I'll pass it over to Jeanette. So melatonin, as you've probably heard, is a naturally occurring hormone that kicks in when you are going to sleep. So it's related to the circadian rhythm. And those of you who were here last year heard me talk a little bit about eating patterns and what time of the day that you eat and what time you go to sleep, and your biological clock, the circadian rhythms, may relate to cancer risk and cancer outcomes. There are currently some ongoing studies testing melatonin for cancer prevention and cancer survivorship. But again, it falls under this sort of gray area of dietary supplements, because in order to be a really good study, the investigator would have to get all the melatonin from the same manufacturer, from the same lot, and make sure that it really was what was in the pill. Because remember, Jeanette shared that we have this law in this country called the Dietary Supplement Health Education Act, and the dietary supplements are actually not required to actually have in the pill what the bottle says is in the pill. So it's not like over-the-counter cold medicine or analgesics or anything like that. It doesn't have to have what it says in the pill. So there can be wide variation, and there is. One of the places that Jeanette showed on her slide was Consumer Labs. And when you are able to see her slides when they're put up to YouTube, go to Consumer Labs, go to their website. It's very interesting because they do a lot of research in their lab where they take supplements and actually analyze what is in them. And it's surprising that a lot of these supplements don't have any of what they say they do. So taking melatonin, you may not be taking melatonin if you go buy melatonin from the pharmacy. So I'll let Jeanette expand on that and talk about resveratrol.
For resveratrol, I think, so that's a compound found in grapes, and I think there's been a lot of research and interest in that area, but I have not seen good, solid, well-conducted trials in humans. I know there are some going on right now, and it's an area of interest, but I think most of the evidence we have has been at the cell and animal level. And like Marian said, it seems surprising, but supplements are not drugs. They are not regulated the same way, and there's nobody out there testing them to see what is in them. So we really have to do our due diligence and be careful.
Wonderful. I'm going to spread it around a little bit for y'all. Some of the coasts on the U.S. map had low prostate cancer. Why? And also, what about a world map?
That's a good question. So I think that some of the difference that you see on the map with regards to mortality reflect both health services, so what's the quality of care and availability of services to treat men in a timely fashion to diagnose them early. But I also think some of it reflects some of the biologic and racial and ethnic differences that we saw. So, for instance, that map really in the southeast portion of the United States, where we have higher proportion of men of African ancestry, had the higher rates of mortality, and that's pretty consistent with some of the national data that we see. As far as internationally, the highest rates of prostate cancer are actually in West Africa. And that's been shown in a series of studies. So that also helps link some of the trends that we see in the United States to some global data. But you have to remember that screening and registry data in developing countries is not as robust as what's available in the United States and Europe. And so that's one of the challenges of studying other countries.
Great. For Dr. Gore, first, they want to link to your survey. I didn't know if that was on your slide. That'll be on YouTube, or it's out of the table or something. So you can address that. But also for the survey network, are you getting responses from all over the country? Are you seeing a trend in any differences from particular regions, such as Southeast U.S., or those with higher concentrations of African-American populations? Yeah.
So that's a great question. I will tell you that is a little bit hot off the presses. So Marty is here, and Marty had an instrumental role to play in us getting the Patient Survey Network approved by US2 International. But that literally was some data that I just pulled a couple days ago. We just sent that survey out a week and a half ago. So we haven't had a chance to do a deep dive into, geographic differences in the responses. We do have that information. In terms of kind of looking at the southeastern U.S., one of the caveats with something like this is we're only accessing people who are on listservs, who are US2 International members who have participated in support groups. And so it's oversampled for white men and their caregivers, and it's probably oversampled for more highly educated individuals. So we really want to try to make this a broadly accessible survey. In terms of reach, US2 is literally international, so we actually have one response from Zimbabwe, but other than that, every other response is from the United States, but all over the U.S. Oh, and I can send a link to Nola so she can distribute it.
So also for Dr. Gore, this question, when men have sexual dysfunction and using a pill to address that, what they note is that you can have improvements upon awakening from dreams, but that on-demand use still fails. Yeah. Do you have any thoughts or comments about that?
Yeah, so that's a frustrating challenge. And, I think what is important to understand about erectile dysfunction in particular is that it's multifactorial, right? A bunch of things have to come together at once to potentiate an erection. And that includes the nervous system, the vascular system, your hormonal milieu, and there's obviously a psychogenic factor as well. And so, some of the impediments to an erection may not be there when you're having sort of your late REM sleep, early morning dream that might be there in the stress and pressure of an on-demand sexual interaction. One thing that I do usually tell patients when they have a morning erection is, the system works. And so that's at least an encouraging sign. Important things about those drugs. So number one, many of them you need to take on an empty stomach. So Levitra and Viagra need to be taken on an empty stomach. So if you've just eaten dinner, that might interfere with the absorption of those drugs. Cialis you can take on a full stomach. Number two, they don't work right away. So Levitra usually works within about 45 minutes, Viagra within about 45 minutes to an hour. Cialis takes 2 hours if you're using it for on-demand purposes. And then last but not least, unlike the injections, they don't work on their own. You have to be in the mood. You have to be aroused. And so you can't kind of force the pills to work.
Great. I think this is a question for Marion. What is the impact of antibiotics on your gut health, both short-term and long-term?
That is a great question. Antibiotics do decrease the diversity of the bacteria in your colon. In fact, when we do studies where we're asking participants to give us a sample of their feces, we don't collect from people who are currently on antibiotics or who have been on antibiotics for the past 3 months. So we're not quite sure what the best remedy for that is, except for after you have finished your antibiotic, make sure that you are increasing diet diversity. You have plenty of whole grains in your diet, and even some foods like yogurt that have some probiotics in them can be a helpful addition. We don't have all the answers on that yet, though, so stay tuned.
And you spoke about tomatoes. What about broccoli? And we may get Dr. Lynn to jump in here as well, but
yeah, I'll pass this over to
you.
Jeanette.
Okay.
Yes, Dr. Lynn should jump in. We actually, there is a lot of research interest in that, and we did conduct a trial here among men who were undergoing prostatectomy. So we gave them a sulforaphane pill or placebo for about 4 to 6 weeks prior to their prostatectomy. We didn't have any significant findings in our study. It's still we're going through that data at this point, but there have been others that have found hints of things. It's just been in really small studies. There was a group in the UK who recently came out with a paper. They fed men a broccoli soup once a week, I think, that actually showed gene expression changes in the prostate tissue once it was, they had a biopsy. But, you know, what that means for clinical practice at this point is still early. We're still compiling evidence for that.
So these are all fantastic questions. There are many more that we can't get to right now. What we'll try to do is modify some of the slides that are going to go up on YouTube to address some of these questions directly, maybe as an update to the presentations, and also clarify some of the acronyms and things that were used. And I encourage you during the next 15-minute break, you can ask questions of these folks as well. So we've got a 15-minute coffee break, restroom break. Please come back in 15 minutes for the next session. Thanks.
This door and then get started.